All right, we will probably go ahead and get started. Just so I make sure somebody give me a thumbs up. Can we hear me? Good. Okay, awesome. Hi, everybody. My name is Ryleigh Semanchik. I am a nutrition consultant for Bluebonnet Feeds and the host of this seminar series. I am very fortunate enough today to have Bluebonnet's animal health specialist, Brittany Rahm, as well as pharmacist Trevor Jeffers here with Exact RX. We're going to bring you a little bit of education on how we can support bleeders through functional nutrition on this episode. So before we begin, I just want to ask that everybody please make sure that you're muted. We just want to kind of minimize that background noise throughout the presentation. Also, as we're going, feel free to go ahead and drop all the questions that you have in our chat box. No need to wait until the end. We might have some open conversation throughout the presentation. So any ideas that pop into your head, just go ahead and drop them below. All right, well, let's dive right in. So what is exercise-induced pulmonary hemorrhage? So throughout this presentation, you might hear Trevor, Brittany, or I refer to this as exercise-induced pulmonary hemorrhage. You might hear us abbreviate it to EIPH or bleeders or bleeding. So for the sake of this presentation, it all means the same thing, and we're referring to the same thing when we say all those different terms. So the Journal of Veterinary Medicine defines exercise-induced pulmonary hemorrhage as bleeding that occurs from the lungs of our horses during exercise. EIPH is the presence of blood that is detected on the tracheobronchoscopic examination after exercise. And it's the presence of red blood cells in a BAL fluid, or both of these combined when done by your vet. Most of the time we see bleeding occur in our thoroughbred or standardbred breeds. These are our breeds of racehorses. However, it's still common in many other horses that are subjected to strenuous exercise, including our barrel horses, our cross-country horses, and even some of our cow horses who are consistently running down the fence. Another word I want to talk about before we begin our presentation is epistaxis. So you might hear that a couple of times throughout the presentation, or you might have heard it just, with a vet or out in the industry. And that actually means when you see blood coming from the horse's nostrils. So not every time when a horse is considered to be a bleeder will they bleed through and out of their nostrils. But when they actually do, we refer to that as epistaxis. So if you hear that word, just know that's what that means. All right, so what are some proposed mechanisms of why EIPH occurs, or what are some causes of EIPH? So probably the most common, and the reason that 99% of our bleeders do actually bleed, is pulmonary capillary stress failure. So what that means is it's an increase in pulmonary blood pressure causing stress and rupture of the capillaries in the lungs, therefore causing our horse to bleed. And so this is the most widely accepted mechanism. However, it's not the only reason a horse could bleed. So another option is just sheer stress and blood flow dynamics. So that means that with extreme exercise, blood flow increases and turbulence occurs, particularly in the small blood vessels of our horse's lungs. So this combination of turbulent flow can cause shear forces on the capillary walls, contributing to their rupturing and then again causing our horse to bleed. The third and probably the least common reason is mechanical impact and microtrauma. So what does that mean? Basically, that is the impact of your horse's hooves striking the ground at high speeds. This may create vibrations that travel through the horse's body and chest, and this microtrauma might also contribute to the capillaries rupturing and in the lungs and increasing our horse's chance of bleeding. So it's important to note that it is estimated that bleeding affects greater than 90% of our racehorses. But of that 90%, only a small percentage actually show blood in the nose. So it's our job as horse owners to be proactive and looking for some of those clinical signs and understanding what they are so that we can maybe catch it a little quicker before we get to the severity of them actually having blood coming out of their nostrils like you see in this picture. So what are some clinical signs? Obviously, the the biggest one is blood in our horse's airways. And so we detect this either by a tracheobronchoscopy or an examination of the tracheal aspirates or a BAL. This is usually done by your veterinarian following intense exercise or exercising your horse. They usually do this right after that to see if they can see some blood present. Poor performance. So let's say last year you bought a horse that was running in the 1D, and this year you really can't pull yourself out of that 2 or 3D. You've done all the things as far as maintenance. We've injected them, we've treated them for ulcers, but they're still not necessarily exactly where they need to be. Maybe that's something we look into. Maybe they're bleeding and we just don't know that yet. Again, epistaxis. So if you see blood coming out of your nose, clearly the horse has an issue. It's pretty severe and they're already bleeding. So pretty clear indicator there. Another one is coughing. So if you're consistently coming out of a pen or following a run, you notice that your horse coughs for a while after that. It's not necessarily a clear indicator that your horse is bleeding, but it's just something to watch along with some of these other signs that could indicate he or she might have EIPH. If you've done an ultrasound or an x-ray of the thorax on your horse, you might see some abnormalities in that. That could be a clear indicator. And then increased respiratory rate. So we're not talking about an increased respiratory rate from exercise. We're talking about post-exercise, you've cooled your horse down a little bit, you've walked back to the stall, you've taken off your saddle, maybe offered them some water, and you see that their respiratory rate is still a little bit elevated. They're still breathing kind of heavy and still quickly, when they should have just been a little bit more calmed down and back to normal. Again, another pretty clear sign that something's not right and going on. And finally, behavior changes. This isn't comfortable. We don't want these horses. I mean, these horses are going to be, not wanting to go into a pen. They're going to be resistant to go into that alley. They might not want to complete the pattern, the task at hand, because they're in a little bit of pain. So, could just be another indicator that something's going on and hopefully lead us to a different answer. So how do we diagnose EIPH? So the first one is basically the presence of blood in the airways of our horse. And this is considered the gold standard of diagnosing EIPH. And so tracheobronchoscopic detection and grading of the blood in the trachea or the bronchi have been validated as a means of assessing the severity of EIPH. And so again, this is usually done with your veterinarian. You're not going to really diagnose bleeding by yourself. So how they do this is they'll often use an endoscope to look directly into your horse's airways for signs of bleeding that they might have had. Another method is a BAL or a lung wash, which allows us to detect microscopic blood and iron deposits in our horse's lungs. Okay, so before we start this slide, I kind of want to make a little bit of a point here that we don't really know why or how our horses necessarily bleed, and there really is no treatment for this. So while you're going to see some do's and don'ts on here, following these proactive management and conditioning tips is not going to prevent your horse from bleeding, and it certainly is not going to treat a horse that is already a bleeder. Our goal here is to offer you some tips and tricks that maybe lessen the severity or keep that irritation in the respiratory down to a minimum. And so what are some things that we should do to support our respiratory health? Let's start with some low dust feeds, okay? These are usually pelletized feed. They've been processed. Maybe they're post-coated in something like a soybean oil. They're not just oats or corn or grain that carry a lot of dust with them. Similarly, we want to reduce some of that respiratory irritation when we're feeding hay. Now, when we say wet down your horse's hay, we're not talking about soaking it like we do for our insulin-resistant horses. We're talking about simply taking a hose, spraying down that hay bag, or maybe we just dip it into a bucket and bring it right back out. The goal is to reduce the dust and allergens that are carried in our hay that our horses are eating every day. Same thing with our ventilation in the barn. I bet you if half of us walked out there to our barns right now, we could probably agree that there's dust, cobwebs, or even the smell of ammonia in our barns from our horses. And all of that over time can just irritate our horse's lungs and our respiratory system. Again, it's not going to cause our horses to bleed, but it certainly isn't going to be a proactive way to get ahead of all of this. From a conditioning standpoint, we want to add in gradual conditioning and breathing to our horses. So let's look at this from the human perspective. If I asked any of you to go run a half marathon tomorrow, odds are you would not be able to do that without conditioning or training for that yourself. So we need to think about that in the way of our horses as well. We can't expect them to go run these record-breaking times in these short periods without conditioning them or breathing them. And so being consistent with your conditioning and breathing, while also adding rest periods. I think it's overlooked, but a super important note to be had is we want to give our horses rest periods during our training program. And that gives us some time to kind of reduce that pressure on our capillaries, allow them to catch their breath, maybe take a second to just maybe get their mind right. And then we can ask them again to long lope or breeze them or do whatever we're doing to kind of help build up that muscle on them. So just as important as it is for us to kind of condition them and build up that stamina, it's also as important that we're resting them while we're doing all of this as well. Let's go over to some of the don'ts. So what do we not want to do? We don't want to grain overload our horses. So what does that mean? Unfortunately, today in our world, a lot of the grains that we see on the market are extremely high NSC or starch and sugars. And so that we know from research that increased levels of starch and sugar in our horse's diet just leads to inflammation. And so we don't want to add any more inflammation to our horse's lungs or respiratory system than they're already struggling with. So if we can look for feeds that are low in NSC, it's just one more tool in our toolbox to be preventative. Next is something I really didn't think about, honestly, prior to this presentation. So it was a little bit of a learning thing for myself. As a nutrition consultant, we spend a lot of times encouraging our customers to give our horses access to free choice forage, hay all the time, as much as they'll eat. And one way to do that is to give our horse a round bale. Well, if you look at the picture, you can see that these horses most likely are standing in the same spot all day, eating from the same spot. And as you can tell, they're kind of eating their way into a hole. What that does is allows your horse to just eat all day while breathing in all of that dust and allergens from their hay. Quick fix, let's just throw a hay net on top of that round bale. It'll reduce your waste and allow them to maybe not create as large of craters and get their nose stuck in there for most of the day. Last is exercising in poor air quality. I know we have people on here from all over the US right now, but I myself live in West Texas, so the dirt is no stranger to us out here. And so I know we can never control the weather or the wind, but if, once or twice a week, we can monitor or be mindful that, oh, hey, it's dusty outside, a little windy, maybe I'll ride later tonight, or I'll get up a little earlier. It just reduces those chances, and it's just one less thing that we can do to irritate that respiratory system. All right, let's move into some common preventative approaches. So traditional treatments, and probably the most common, I'm sure everybody on this call has heard of furosemide or what we call Lasix. Lasix is a diuretic that can reduce blood pressure in the lungs. Now, while this is extremely effective for our horses, Lasix can lead to an extreme electrolyte imbalance in the horse's body, and we'll cover that in another section of the presentation. But another option, which is a non-invasive option, is nasal strips. The idea behind nasal strips is to open the horse's nostrils and basically ease airflow resistance, allow them to get deeper breaths and get more air in there. But I do want to make a quick note that a low quality treadmill investigation that is assessing the presence or absence of post-exercise blood in the airways did state that nasal strips were ineffective in preventing EIPH. So we don't want you to not use them because they're a great tool to also have with you to increase the air that our horses are getting into our lungs. But we want to make sure this is not the only thing that you're doing to be preventative, because in and itself will not prevent your horse from bleeding. So we just wanted to say that they're a great tool, but not the only thing that you'll need to kind of combat some of these bleeders. And then finally, like we keep saying, a controlled exercise program. You know, we want to condition these horses and gradually build up a tolerance to these intense physical exertions that these horses are getting, just so they can handle them more in a performance or show setting.
Okay, thank you so much, Ryleigh, for going over that. I'm Brittany Rahm, and I'm going to start the functional nutrition piece of this webinar. So maybe go back one. Oh, what's happening? All right, so most importantly, when you are giving Lasix, we all know it dehydrates our horse. So we have a product called Hydrate and Recover. Electrolytes, I would say, are the most important to be proactive and reactive in this situation. Now, when you have horses that you're competing on back-to-back weekends, majority of the time throughout the week between those weekends, they are still recovering from those doses of Lasix that you had to administer. If they're a horse that you're running once a month, you can definitely just give them some electrolytes after the run. But know that when the Lasix is in the system, even when your horse is done running, it will still be pulling those fluids out of the body. So we usually recommend give an electrolyte dose right after the horse is done running, and then wait 4 hours, give them another dose, and then that following next morning. Now, if you're going to be running again that next evening, the biggest deal with these horses is keeping consistency. So you're always going to give, say, 4 cc's of Lasix 4 hours out. Same with your electrolytes. You need to be really consistent with those electrolytes. That way your horse is always at the same hydration levels. Equally as important as the electrolytes when we're talking about muscle recovery, there's oxygen, there's glycogen in those muscles that's also getting pulled out after strenuous activity. And so it's important to make sure we're allowing those muscles to have the proper support to recover as well. Now, when you take a horse in a typical strenuous activity setting, it usually takes 3 to 4 days for that horse to properly recover from that activity. Then if you take a horse that's dehydrated, that's an additional 3 to 4 days. So we're looking at 7 to 8 days before that horse actually gets back to normal with their electrolytes. So that's why it is so important and so crucial, especially if you're running back-to-back days during the weekend and maybe a Tuesday night jackpot or a Wednesday night jackpot, to make sure that you're staying on top of this hydration. Now, even when a horse drinks water, a lot of times people will say, well, my horse drinks really well. That doesn't mean that the water's actually getting to where it needs to be. And when you have such a short period of time before that horse runs again, we need to make sure that we are administering something that's going to improve the cellular hydration and allow that water to get into the cells. If you're just running once a month, then I wouldn't worry about, giving this daily. I would just give it, post run, and then maybe the next day and then roll on. If you are running consistently, then that type of horse would need to be on something like this daily just to keep a consistent program. Now we have settings where, like Ryleigh mentioned, where you have horses that are stalled, they're eating out of, these really nice corner feeders. Their head is down in these holes where they're breathing in the dust from the hay. Maybe they're in a barn and you're, up in the north and it's in the middle of winter and the barn's all closed up and there's not proper air ventilation. You're going to have lung irritants in the air that these horses are breathing in. And these lung irritants are going to cause inflammation in the lungs. So it's important to also take in those environmental factors. Then you have horses that also have upper respiratory disease, COPD, asthma, on top of being a bleeder. Those type of horses would need a more proactive approach in helping them reduce that inflammation in the lungs. So management is a huge piece, and then you can plug in the functional nutrition as well. Certain omega-3s that come from fish oil and flaxseed will help reduce inflammation and keep those respiratory tissues healthy. And then as well as antioxidants like E and C will help neutralize those free radicals and reduce that chance of those oxidative stress in those lung tissues. Now, our bleeder protocol, Bluebonnet's bleeder protocol, is the Lifeline Plus with the Surge. Now, if I had to say what is one supplement that you can do for your horse to aid in respiratory health and reduce that respiratory inflammation, improve those elasticities in those capillaries to withstand more pressure, it would be the Lifeline Plus. The benefits of the Lifeline Plus are that you also get the benefits of gastric health, leaky gut prevention, increased stride length, but if you have a bleeder, the sole purpose of the Lifeline is going to help reduce that inflammation and improve the lung health in those tissues. Now, if you have a horse that has recently bled, maybe they've bled through Lasix, and we need to speed up healing, we need to reduce inflammation, I usually recommend to put those horses on Lifeline at a 4 to 5 scoops a day to help jumpstart and kind of, play catch up. Now, the other piece to the bleeder protocol is the Surge. Surge is given only on the day of the race, 1 hour prior. And when Surge is given 1 hour prior, it will help reduce the blood pressure in those capillaries. So Lifeline is helping the elasticity part, and then the Surge is going to help reduce that blood pressure and hopefully reduce the chance of the EIPH. We have these bleeder protocol instructions. You're happy to take a picture of them. We will also send these in a follow-up email as well, as the Surge comes in a powder form or a paste form. And I'll hand it over to Trevor.
Cool. Can everyone hear me? I don't know if this is working or not. Cool. Okay. First of all, thank you, Ryleigh and Brittany, for allowing me to come on, and thank y'all for showing up. Pretty cool opportunity, and hopefully this might be a review for some of y'all. Hopefully we can shed some light on some new topics that maybe may or may not have thought about before, but let's talk drugs. So loop diuretics is going to be the class of drugs that furosemide or Lasix belongs to. Excuse me, there's 4 drugs that belong to this class. There's furosemide or Lasix, there's torsemide, there's bumetanide, and ethacrynic acid. The first 3 are more commonly used, and they work in the body by preventing the kidneys from reabsorbing sodium, chloride, potassium, and other electrolytes from being reabsorbed into circulation, and water will always follow high solute. So basically you have high salt concentration, high electrolyte concentration in the blood. Water is going to follow that, and then it's being excreted through urination. So like has been mentioned a few times on the webinar already, replacing electrolytes is crucial. It's super important. Water will kind of follow, right? So we give some kind of a loop diuretic, most commonly Lasix. Water is then going to follow those electrolytes that are pulled into the bloodstream through urination. Then we replenish with electrolytes after the fact, and then that promotes them drinking water. So you've kind of got a cycle where water is always following these electrolytes. So this is kind of an interesting table. This was pulled, the studies that were done in actually heart failure in the human setting. And these are like I said, these are the most common drugs that are used in terms of loop diuretics. So we got furosemide or Lasix, torsemide, and bumetanide. That first row you can see is potency, meaning how good the drug is at doing its job. So you can see that bumetanide, Bumex, is 40 times more potent than Lasix, and torsemide is twice as potent as Lasix or furosemide. So you've got some relative potencies going on there. Your oral dosing, so oral to IV, you can see that Lasix is the only one that's a little bit different than the other 2. What we want to take away from this is that an IV dose, say, of 10 milligrams of Lasix, if you're to convert that, or say we're in the hospital setting, and we convert that to an oral dose, you actually double it. So instead of 10, you would actually give 20. As you can see with torsemide and Bumex or bumetanide, they're 1-to-1. You don't change the dose from IV to oral. This will kind of come in play a little bit later on. Bioavailability. So we've got the amount, let's see, so the amount of drug that actually gets absorbed into the bloodstream and can have effect. So there's a huge range when it comes to Lasix. You can see anywhere from 10%. Now, remember, this is pulled from human data, but a lot of it correlates to horses, and we'll talk about that in just a second. But you've got a really wide range here. So you take any of these by mouth, and then this is referring to the amount that is going to absorb through the intestinal wall, through the stomach lining, into the bloodstream and have effect. You can see that torsemide and Bumex are nearly completely absorbed. Half-life of the drug in pharmacy lingo is the time that it takes. So you take a drug, there's a peak concentration. The half-life would then be the time it takes for 50% of that drug to then leave the body. So there's, once again, another range here. So you can see that torsemide acts a little bit longer than the other two. Duration effect kind of mirrors the half-life. So Lasix is the most studied and most effective treatment. Excuse me, there is no treatment. So preventative measure in preventing EIPH. So this is in all reality, this is a very, very it may seem simple that, like, yeah, okay, so increased pressure in the pulmonary capillaries or increased blood pressure in the lungs can then cause them to burst and the horses bleed. But there's a lot that goes on in the background that you may or may not have thought about. So a third of a horse's fluid or water content is found extracellularly. So that means in the bloodstream. 2/3 of that water content is actually intracellular or in interstitial spaces, so somewhere else. So when there is, say, a fight or flight response, doesn't matter if it's a human, horse, whatever it is, there's going to be some fluid shifts that occur to optimize chances of survival, if we kind of think very, very primitive. So what can happen is that actually we get these horses in stressful situations. We can actually see fluid shifts that occur from intracellular to extracellular. And so you actually have water or blood volume that wasn't accounted for prior to that is now at play. So it becomes a very, very tricky picture. So when I bring that up to say this is how Lasix works at preventing EIPH. So if we think here, Lasix is going to, as we talked before, you're going to get urination because of electrolyte, preventing electrolyte reabsorption. That is going to lower total blood volume. So lowering total blood volume then down the line can change pressure in the lungs. So you can decrease pulmonary arterial pressure and pulmonary wedge pressure. That actually takes time. So this is professional opinion here, may or may not be shared other places. Lasix and other loop diuretics don't take 3 to 4 hours to work. They really don't. They're going to reach peak concentration within an hour or two. My opinion is that longer time, because you hear people that can run after 2 hours. I think that longer time also allows for redistribution of that water, right? So they're losing it from the bloodstream. The body is then going to come back into a state of equilibrium. So the fluid is going to shift back into the bloodstream to replace what was lost. that takes time. That isn't immediate. That's not, we gave the drug and these shifts are going to happen and here we are. So I think part of that time, part of that window, part of the 3 to 4 hours that you hear about is also allowing for some of those fluid shifts to occur, which then will allow the pressure in the lungs to actually change, if that makes sense. Hopefully that's coming across clearly. So Lasix decreased pressure in the lungs, decreased likelihood of those capillaries failing due to stress. Common dosage, so there's probably been around 17 or more studies that have been done on Lasix in the setting of the IPH. Most commonly, the dosages are 0.5 to 1 mg per kg. So we have, let me put that into like a cc so you can, so 0.5 mg per kg on a 50 mg per mil vial of Lasix is going to be your 4 to 5 cc range. 1 mg per kg is going to be your 9 to 10 cc range. Most commonly, what has been studied is that 0.5 mg per kg, so your 4 to 5 cc range. Next most common would be your 1 mg per kg, which is that 9 to 10 cc range. Tricks of the trade. So what does controlled room temperature mean? Controlled room temperature doesn't mean in the door of the trailer when it's 110 degrees outside. Controlled room temperature 68 to 77. We don't live in a perfect world. Is your vial of Lasix going to, break down after being stored in the trailer for a weekend? Probably not. I mean, we can be real. But the longer these vials hang around, drugs will degrade over time, even if in the best storage conditions. One other thing that may or may not be widely known is that Lasix actually needs to be protected from light. So in the human hospital setting where I came from, we make a Lasix IV for a patient. We actually cover it with a brown bag to protect it from light while it's hung and infused into that patient. Reason is the drug can actually break down when it's exposed to light for an extended period of time. They've done a couple of studies on this actually, and they found after prolonged exposure to light, the drug can actually degrade up to 60% or more. So you think you're giving a dose of 250 milligrams or 4 cc's, you're actually maybe only given 1.6 or 7. So that makes a big difference. So then when we talk about bleeding through Lasix, some of these confounding factors, some things that we can control, we can, be proactive, not only in the other issues that we talked about, but also when it comes to drugs, to help make that clinical picture as clear as possible, because it's very complicated clinical picture. The Lasix will turn like a yellow, brown, or orange color after that degradation starts to occur. So if you see that, probably time to get a new vial or go see your vet and see if we can get you set up with something different. IV is the preferred route if we're going to utilize Lasix. Slow injection. If Lasix is given by mouth, it's only absorbed about 5%. So you're not going to get a whole lot of effect out of it. And the IM absorption is very sporadic and unpredictable just because of how it's going to be absorbed from the muscle tissue into the bloodstream. Depends on how much vasculature is feeding that muscle. So it's kind of unpredictable and sporadic there. So just so you know that I'm not pulling a rabbit out of the hat and just spitballing here, this is the study that they did in horses when they gave Lasix by mouth. And you can see this graph there on the left side. So your up and down axis there on the left is actually urine volume in liters. The dark line, the black line, is the IV dose. The gray line is the by mouth dose. And the white line is the control. So no Lasix. You can see that if they gave it by mouth or didn't even give Lasix at all, it was about the same. The authors do make the comment there over on the right that a recommended PO, which is by mouth dose, cannot be calculated from these results because of poor systemic availability, around 5% of Lasix after administered by mouth. So one thing to kind of think about, this kind of creates a problem for us, some of us that either don't want to stick our horse or the horse doesn't want to be stuck itself. So there's a couple of different issues that can arise. So this is where we can maybe glean some from that chart that we reviewed earlier. So there are other drugs in this class, and one of them actually has been studied in horses. You can go ahead. So torsemide is the one that has been studied. Now, I want to make something clear. This drug and this study was not in the setting of EIPH. This was in the setting of heart failure. So in the setting of heart failure, these horses are way more fluid overloaded than what we're trying to accomplish here. So you can see that on that left, that up and down y-axis there again, they were getting 30 plus liters of fluid off of these horses. They were using a fairly high dose. Proof of concept, the other loop diuretics will get fluid off of horses, but you got to dial the dose in. They did make the statement that the torsemide was actually absorbed after administration by mouth in all the horses that were studied, and they reached plasma concentrations similar to those observed in previous studies conducted in other species. Humans being one of those, dogs, rabbits, some of those other mice, some of those other species. So that 80 to 100% that we saw reported earlier is kind of what they found in this study when they gave torsemide by mouth. So an effective oral option. That you're good. This loop diuretics, Lasix specifically, is the only thing that has been shown to be effective at preventing EIPH. Like I said, the most literature surrounds this, and there's very high grade evidence surrounding that. There's been some really, digging into equine literature and studies is sometimes troublesome because it's hard to get big sample sizes. You may get 6 to 10 horses that were studied, and then you're trying to extrapolate that to populations. So, but there were some studies that had hundreds of horses involved. So it is a great drug at doing what it's supposed to do, but it is a very fine line and kind of teeter-totter approach, because the oxygen that is delivered to the muscles that allow them to then function is carried through the blood. So if we over-diurese, meaning lower blood volume too much, then they're not going to perform. If we under-diurese, then we're increasing our risk of EIPH. So the big thing, in my opinion, here is to be consistent. No matter what you do, whether it's electrolyte, giving them electrolytes, allowing them to drink water, whatever it is, be consistent and try and control as much that you can so that the confounding picture doesn't get more complicated because of those fluid shifts and everything else that we may see. If we're consistent and we store the drugs properly and we give it time to actually work, not only just, hey, they're peeing, the drug worked. There's also other things that are going inside of the body that we need to allow time for to really occur. But consistency, I think, is huge in this clinical picture. There are a lot of other drugs that are talked about, utilized, that I hear about, and we can chat about them. I'm going to kind of kick it back to Ryleigh and Brittany, and we can proceed however they'd like.
Thank you, Trevor. I know that everybody kind of submitted what their EIPH protocol is. I know there was quite a few that said Lasix, which is great. I know we had one question come in what is the minimum amount of Lasix you can give? How would you appropriately answer that question?
I wish I could tell you, to be honest. So here's what I would say that the best approach would potentially be that probably never happens. So if you give, say, 10 cc's of Lasix, kind of the ceiling, not really the ceiling dose, but a high-end dose, and then you back it off until they bleed, and then you can bump up so you know exactly where that point is. Now, that point can change based on all of these other factors that we've been discussing. So that's complicated because at the end of the day, it is a mg per kg dose. What I mean by that is a weight-based dose. So the minimum would be whatever is effective at preventing EIPH. The only way to find that is to administer something. Now, Ryleigh had mentioned this before, and I completely agree. This is probably a not if, but when and how bad situation. There's been some studies that they've done on treadmills that show that even a horse galloping through a pasture, their pressures get up high enough that can cause some bursting of capillaries. So that's where those BALs kind of come into play, where you're actually getting fluid out and looking for red blood cells, because they may not have, an active, not really an active, but they may not have depiction of bleeding in the scope, in their endoscope, but that's where that BAL comes. So that's where that blood is going to settle. So I wish that there was an easy, give me the weight of your horse, I'm going to give you a dose, and I'm going to tell you exactly when to give it. It's kind of a trial and error, unfortunately.
So what about horses' weight? I have a 1,400-pound barrel horse, and then you have those 1,000-pound barrel horses. And sometimes, it's usually I just give 4 cc's of Lasix 4 hours out to every horse. So is there any kind of deciding factors with the weight of the horse where you would bump it up or down?
Potentially, right? So if you think of a big pitcher of glass, right? So a bigger horse is going to have more blood volume per se. Not that that blood volume is going to act any differently than a smaller horse, but the drug amount is going to be dispersed into a bigger, I don't know how to, so if you've got a 32 ounce and a 64 ounce and you're giving the same drug amount, it's going to be more potent over here than it is over here. I guess it might be a simple way to kind of put it. So like we said, like a lot of these were 0.5 mg per kg. So that kilogram is that body weight. So it's dosed based on body weight. So it's something to consider and talk to your vet about. It may be that you need to be on the higher end of that dosing regimen. But it's not to say that those bigger horses are more sensitive to the drug and you need to dial it back. It's kind of once again, it's kind of a trial and error situation.
Right.
Here's one that came in via a message from a girl who could not get on here, but she was talking about running multiple times in one day or multiple times in a weekend. Do you recommend redosing your Lasix multiple times a day? Do you recommend once? How do you handle that if you have multiple runs a day or a weekend?
So hard. So hard. Like that chart showed. So just because the drug starts to take effect at maybe, reaches peak concentration, maybe an hour or two down the road, you're going to see. So in pharmacy, we have that half-life situation that we talked about, right? So that is the time from peak concentration to half gone. It usually takes about 4 to 5 half-lives for that drug to be completely excreted from the body. So that means if that number was 4 hours, then you're talking 50% in 4. So it would be 4 hours times 4 to 5. So you're talking 20. So you may, now granted, at hour 20, are you still getting effects like you did at hour 1? Definitely not. But it does kind of make kind of a confounding picture, right? There's also things that you only are going to know about your horse. So are they one of those that's stressed out and isn't going to drink in between runs? Well, I'm probably going to approach that horse and redosing them a lot different than one that goes down and sucks 3 buckets like right now. So, right. So you've got to remember with Lasix, we're playing with blood volume at the end of the day. So anything that can affect blood volume, which would be rehydration, is how I would kind of gauge that. I don't know that I would, especially same day, I don't know that I would hit them with another full dose. But it's once again one of those things, like you definitely don't want to over diurese to where they're not going to perform because they're not getting oxygen delivery, but you don't want to under diurese either. So it's some of those other factors I think that would be very important in that studying would be how do they act in between runs, and that would kind of determine where and how much, or if and how much. Excuse me.
So what about like the torsemide? Since it lasts a little bit longer, the oral sister drug to Lasix or it's fine. Would that be a more appropriate setting to use? Say if it was a junior rodeo horse that had multiple events throughout the day, like something that would last a little longer?
The short answer is we really don't know. It's been studied in the setting of heart failure. And I worked a long time because this was always an issue that I had heard about, that there was never really an effective oral option. And so that's why I dug into the literature and tried to figure something out. But it's not necessarily new. Torcemide's been around for a long time, and I know internal medicine vets that have been utilizing it for a long time. But in the setting of EIPH, it is new. Now, with that being said, based on the way that the drug works, theoretically, it could be. Just because it is going to act a little longer. And you're also not, so let's talk about really quickly oral absorption of any drug versus IV, right? So if you give something IV, your absorption is 100%. As soon as that needle goes into the vein, they're getting the whole dose. You don't have, unless obviously you don't get it all into the vein, heaven forbid, they're getting that whole dose. So what happens when they give it orally is you get more of a gradual onset and a gradual offset instead of, hey, we got the whole thing now and we're just going to work on excretion. The body is going to work on excretion from that point forward. So you get kind of more of a gradual curve of absorption and excretion. And it definitely, like we saw in that, it can last, twice as long per se. Now, granted, how much of an effect are you getting at the end of the day towards the first? I don't know. I don't know that anyone does.
Okay. So if you have a horse that say bled through 4 cc's of Lasix, they give the appropriate time off. I know my personal opinion, and with the vets that I have worked with, I like to give at least a minimum of 2 to 3 weeks off after a horse actually bleeds out, just to give them that rest period, time to heal. When you go back to re-administer Lasix again after a horse has actually bled through, and they have, would you recommend bumping that Lasix up?
Work with your vet. My opinion, I don't have prescriptive authority, but my opinion, probably. Now, I think step number 1, control all the confounding factors that you can. So how old is the vial that you're using? How has it been stored? Control all of those things that we discussed and talked about so that those aren't an issue. And then we're on a level playing field and we can start from there. So control everything that you can, make sure that you're consistent with your program, whatever your program is. And oftentimes, less is more, but yes, I would think did they bleed through because of things that we could have controlled, or did they really, was the dose not high enough? At the end of the day, we're not treating anything. We're trying to prevent. So if your dose was ineffective at preventing, then yeah, the only way to be would be to go up.
So you were talking a little bit about how giving Lasix in an IV versus orally is more absorbable. So talk about a little bit of the effects. Like if we're giving it through an IV versus orally, are we depleting more electrolytes in our body? Do we need to be more cautious or more diligent about adding in follow-up electrolytes? Are the maybe quote unquote side effects worse when we give it in the vein versus giving it to the horses through the mouth?
Depends on the drug. So if we're talking Lasix to Lasix, IV to oral, if you give it orally, you're really not getting absorption. So it's really not having much of an effect. And therefore, you're not going to have to worry about many side effects. If you're giving it in the vein, I don't know that it would be any worse or better than if you gave, say, torsemide or one of the other loop diuretics by mouth, but it would be the time, right? So if we think of like we mentioned, you're really not getting, like, absorption happens fast when you give it IV because it's as you administer. Versus oral, it's going to take time to go through it's going to take time to get into the intestine, to get absorbed through the intestinal wall, through those vessels, get into the bloodstream. But it's more so the time that it lasts. So it would be kind of a drug specific question, not necessarily like IV to PO of the same drug versus one drug to another, I guess, if that makes sense.
Let's see. Another question. I use albuterol. Is there any benefits to that over Lasix?
Great question. This is another one of those confounding pictures. So in the true, like, just trying to prevent EIPH, bronchodilators, which albuterol, clenbuterol, some of those buterols haven't really been shown to have any difference than no therapy at all. Now, if you have an upper respiratory airway disease on top of that you're trying to deal with, then by all means, yes. But if there's like an upper airway disease is going to cause some of the things that I feel like they get kind of very intermingled here. So you definitely work with your vet. If they do have some kind of an upper respiratory airway disease or something of that nature, then how albuterol, clenbuterol, some of those work is they're opening up the airways in the lungs. So they're binding and they're actually dilating the airways to allow more air to move through. But in just a true setting, trying to prevent EIPH with a horse that doesn't have any kind of a airway disease, probably not necessarily.
Okay. Let's see. Is a low dose of Lasix, like 2 to 3 cc's, going to have any benefit at all?
It really depends on your horse. What happens after? So if you're effective at prevent. Now, here's the tricky thing, right? So in a perfect world, you would give 10 cc's, scope them. Did they bleed? Or, yeah, they did bleed, but how bad was it? So let's talk about severity and not not did they bleed or not, because chances are at some point they're probably going to. So how bad was it? And then, okay, they didn't. Let's bump the dose down and then scope them. Like, I don't know that anyone's going to go to that length. So that would be like, yeah, in an ideal world, we could give a dose, scope them after, or do a BAL or some of these things. Look what happened. Okay, we're okay with that. Let's bump the dose down. And then, okay, now we're at a place we're not okay. Let's bump it back up to where we were and cruise on with our lives. At the end of the day, that's probably like we don't live in a perfect world. So it really is kind of that trial and error. So it's hard for me to say that. It's really hard to say that this dose is going to work or not work for this horse. Like it really depends on that horse and how it reacts to the drug. I really do. I wish there was a blanket statement that we could just, there it is.
Yeah, it's definitely a very tricky thing to navigate, and all horses are different. I know when I've administered Lasix, there's some that pee immediately. There's some that wait 30 minutes to pee. Obviously the factor of how effective or how potent my Lasix is, if I've been storing it properly, comes in. I mean, I know there's a lot of factors, but we do appreciate you answering all these questions to the best of your ability.
I know.
Somebody did say, did I understand correctly, when giving Lasix orally, you should double the dose?
So that, in theory, yes, but no matter what you, so this gets really complicated. So if in theory, yes, but you got to also remember how well it's actually absorbed. So doubling the dose, if it's only being absorbed by 5%, you may have to 40 times the dose to get what you were with IV. So I think what they've shown from that study is that, and granted, now this is, am I saying that you're never going to get effect if you give it by mouth? Heavens no. I mean, you'll get some effect, I would hope. If that drug is getting absorbed, goes into the bloodstream, you're going to get effect. Now, is it going to be predictable and the same? Maybe, maybe not. So it's really hard to give it by mouth because you've got two different pictures going up, right? So you've got the potency of the drug, how good it is at doing its job, but also how well it's absorbed. And they've shown that it's really just, it's not absorbed. So what you're counting on if you give it by mouth, if you drop the IV and shoot it in their mouth, you're counting on that drug to get absorbed through the intestinal wall, the stomach lining, and go into the bloodstream there. So that's where that 5% comes in. You've got 100% of the drug you gave, and only 5% is making it through those, then through the intestinal wall, or makes it into the bloodstream.
So what might be more effective would be just using more of an oral, a medication that's more designed to give orally, like the torsemide. If that horse doesn't like to be stuck, or you don't like to stick your horse kind of thing, that would be probably the more safer route to go.
Yeah, more effective option for sure.
Okay. Well, we really appreciate, sorry, Ryleigh.
We're good. I just want to touch on one more thing. A couple people, actually quite a few people, part of their breeder protocol is like steroids or a nebulizer. And so I just want you to touch a little bit on that, like what your opinion is on that. Do we think that they're effective in combination with some of our Lasix? What do we do here with that?
Yeah, for sure. The use of steroids, so you can either give steroids obviously by mouth, you can give them in the vein, or you can neb them. It's kind of recent literature has shown that it's kind of an old school way of thinking that EIPH itself causes inflammation. They've now taken, a few of the more recent studies have actually taken blood and inserted it into the airways to see what happens. And they found that after 14 days, it caused no inflammation to occur. So really the more recent literature is showing that EIPH itself, or, we didn't prevent it, they bled, that itself does not cause inflammation, but those other, where those beta agonists, albuterol, clenbuterol, are effective is where that inflammation occurs. So if you've asthma, that's a constrictive airway disease. So there's inflammation there. The drug, or the job of those drugs, is to open those airways back up. So you've got your albuterol inhaler, your rescue inhaler, you take a puff, it's going to relax and open up and dilate those blood. So in short, if your horse has a respiratory disease that is confounding that clinical picture, then yeah, under the direction of your vet, beta agonists, possibly steroids, Steroids are tricky though. In my professional opinion, I think we use a lot of steroids in a lot of different settings, and steroids are not benign. They can mess with your blood sugar. They can weaken immune system if you give them for a very long time. They're definitely not a benign drug. They have a lot of effects downstream if you give them for an extended period of time. So kind of depends on the specific horse and what's going on. So with the direction of your vet, if they have a respiratory airway disease on top of this picture, then for sure, they can recommend those, and they'll definitely be effective. But in the setting of a horse that doesn't have that, probably no need.
Okay, thank you. That was useful. So we have a lot of big questions coming in. So, but for the sake of time, I think we're gonna grab one more. And then we'll give you all some contact information to reach out to us if yours did not get answered. But last one is, are supplements with vitamin K beneficial?
Say it one more time.
Are supplements with vitamin K beneficial?
Come here.
Okay. There is a lot of drugs that have been used for a very long time that are what we call procoagulants. So what would be in this? So you would have tranexamic acid, TXA, aminocaproic acid, part of Kentucky Red. So a lot of these are going to be your procoagulants. Once again, to answer this question, I'm going to remind us of the clinical picture that we have going on. We are not treating an active bleed, right? So if they were actively bleeding or hemorrhaging, then the dose of those drugs that you would give would be a lot higher than what's utilized in EIPH. Recently, I dug into a little bit of literature that actually shows that horses are actually a lot more sensitive to those drugs than humans are, to some of those coagulants. So it personally, my professional opinion, it makes me nervous because you're giving something that can cause a lot more problem. Like, so heaven forbid we get a pulmonary embolism or a DVT, or, they clot and that clot goes into their lung. That's going to be a lot worse. So a lot of these procoagulants that are given, they make me nervous just because we're not treating an active bleed. There's very low grade evidence that it may decrease severity, but you've got to recognize that these horses under stress and exercise are actually probably already a little hypercoagulable, and then you're giving a coagulating agent on top of that. So you're really kind of making them very prone to clotting, where the natural progression of just them being them is going to, unless they've got, so say maybe they have a clotting disorder, maybe there's a place there. But most horses, my professional, I don't like them.
Okay, awesome. I'm going to share back to this screen really quickly for everybody. There's some contact information on here. There is my contact information, Brittany's, as well as Trevor's. Be on the lookout for a follow-up email from us. We did record this, so anybody who could not make it last minute will get a copy of that. There will be an exclusive 15% off for anybody who attended today on any of the products that we talked about. So that code will be in that email. And like I said, we had a lot of great questions that came through the chat that we would probably be here all night if we answered every single one. So we want to make sure your questions get answered. So feel free to reach out to any of the phone numbers or emails that you see on this page or that you'll get in the email in the next day or two, and ask us those questions. If you want to get signed up with a nutrition consult, we'll make sure you guys have access to that as well. Or if you have any drug questions for Trevor at all, he's available to you guys for any questions that you might have. We appreciate everybody hopping on today. And thank you, Brittany and Trevor. Your expertise and knowledge was great. And so I look forward to working with you guys, and hopefully everybody enjoyed the presentation today.
Thank you, Ryleigh, and thank you, Trevor.
Thank y'all.
Yep, like every horse is a specific individual, so I would highly encourage to reach out to Trevor if you have specific cases. And then on the functional nutrition side, you know, we can tailor each program to each horse individually. So thank you all for attending.